Hello, and thank you for joining today's webinar, Revaccination with COVID-19 Vaccines After Anaphylaxis, which will cover NACI's updated recommendations on vaccinating individuals with severe immediate allergic reactions to COVID-19 vaccines or to their components. My name is Antonella Pucci, and I'm the Project Officer for CANVax at the Canadian Public Health Association. It is our pleasure at CANVax to be hosting the Public Health Agency of Canada's webinars on COVID-19 vaccines for healthcare providers. To learn more about this webinar series, please visit our website at canvax.ca in the link you see on the screen. Before we begin, we want to acknowledge that the Canadian Public Health Association's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit and Métis people, and their governments in realizing meaningful truth and reconciliation. Next slide, please. As for a bit of housekeeping, it should be noted that this webinar is taking place on Zoom. If you have any questions regarding technical difficulties, please contact canvax@cpha.ca, and we will reply to you as soon as we can. If multiple people are experiencing the same problem, we'll address it live via a broadcast message in the chat. That being said, the host will use the chat for extra communication to participants. Please keep an eye on that tab as well. The question and answer session today will be focused on NACI's updated recommendations on revaccination with COVID-19 vaccines after anaphylaxis. Please submit or upvote, rather, your questions to the presenter in the Q&A box at any point during this webinar, and they will be answered at the end of the presentation. Due to time limitations, not all questions can be answered. Our webinar is being recorded and will be made available on canvax.ca and on CPHA's YouTube channel a few days after the end of this presentation. Presentation slides will also be shared. We would also love to get your feedback, so please fill out our 5-minute post-webinar survey in the evaluation email we'll be sending after the webinar. And finally, if you haven't already registered with CANVax or subscribed to our newsletter, visit canvax.ca today to do so. Now I'd like to turn the floor over to Stephanie Elliott, who is an advisor in vaccine confidence with the Public Health Agency of Canada, and who will be our moderator for today's presentation. Over to you, Stephanie.
Thank you, Antonella. Good afternoon, everyone. I'd like to first begin by thanking CANVax for their support in hosting today and making this webinar possible. Now I'll take the opportunity to introduce our speaker for today, Dr. Alyssa Abrams. Dr. Abrams is a medical specialist with the National Advisory Committee on Immunization Secretariat. She's an assistant professor in the Department of Pediatrics, section of Allergy and Clinical Immunology at the University of Manitoba. She is also the president of the Allergy section of the Canadian Pediatric Society. Next slide, please. Here are the disclosures for today's presentation. Next slide, please. And I would like to present the learning objectives for this talk today. So you should be able to explain the October 22nd, 2021 guidance from the National Advisory Committee on Immunization regarding vaccination of people with previous severe immediate allergic reactions or anaphylaxis following COVID-19 vaccines or to their components. We'll examine the evidence and the rationale behind those recommendations and locate resources to facilitate safe vaccination or revaccination of people with severe immediate allergic reactions or anaphylaxis following COVID-19 vaccines or to their components. Now for our presentation, I welcome Dr. Abrams.
Hi, everyone. Thank you for the opportunity to present today. I'm going to start with an overview of anaphylaxis, and a really important take-home point as we're looking at allergic reactions after COVID vaccines is that anaphylaxis is a clinical diagnosis. So there are lots of different ways that anaphylaxis can occur, but ultimately you diagnose anaphylaxis based on a constellation of signs and symptoms. In general, for anaphylaxis, we say you have to have 2 different organ systems involved to diagnose anaphylaxis, but that's not always the case. So if there's a serious reaction after a known exposure to an allergen, like there's hypotension after known exposure to an allergen, you can diagnose anaphylaxis even if there's only one body system involved. Signs and symptoms of anaphylaxis include, but are not limited to, skin symptoms. And skin symptoms are by far the most common symptoms in anaphylaxis, most commonly hives and swelling. Respiratory symptoms, so you can see wheezing or coughing or difficulty breathing. Gastrointestinal symptoms like vomiting, diarrhea, severe abdominal pain, and less commonly cardiovascular symptoms like decreased level of consciousness, low blood pressure, or a shock. Now, anaphylaxis is an immediate generalized hypersensitivity reaction. It happens quickly. To have anaphylaxis after a vaccine, you have to have a reaction within 4 hours, but practically, most severe immediate allergic reactions occur within 15 to 30 minutes after vaccination. Next slide, please. So as I mentioned, anaphylaxis is an umbrella term. It's a constellation of signs and symptoms that are related to release of mediators from mast cells and basophils, from allergy cells. But there are different ways that anaphylaxis can occur. And most people are most familiar with the IgE or immunoglobulin E mediated mechanism. And that's the mechanism we have historically thought about with vaccine reactions. It's the mechanism we think about, for example, with food allergic reactions too. And what you have with an IgE mediated reaction is you will get IgE specific to an allergen, which is usually a protein that binds to high affinity receptors on mast cells and basophils. And then when those IgE are re-exposed to the allergen, you get cross-linking, you get cellular activation, and you get release of a bunch of mediators that cause this constellation of signs and symptoms. But what's really, really important, main take-home message, is that anaphylaxis does not just occur through this IgE mediated mechanism. There can be non-IgE immune mediated mechanisms, activation of the complement cascade or the coagulation cascade, or through IgG. And you can also have non-immune mediated anaphylaxis mechanisms as well. And the reason this becomes important is because one of the hallmarks of an IgE mediated reaction is that it's reproducible. So if you think about a child who's peanut allergic, when they eat peanut, they may not have the same reaction, but a hallmark of a food allergy is re-exposure causes repeat reactions. And I'm going to get into the studies in a little bit when we look at reactions following the COVID vaccines. But what we're seeing is re-exposure doesn't usually lead to repeat reactions. So there's more and more evidence that the reactions following the COVID-19 vaccines are likely not IgE mediated, and as a result, may be less likely to recur with subsequent exposure. Next slide, please. So now we're going to talk about the incidence of anaphylaxis following COVID-19 vaccines. It's approximately 2 to 10 cases per million doses of vaccine administered. So this is an exceptionally rare event. It is higher than the incidence of anaphylaxis following other vaccines, and the historical rate there is about 1.3 cases per million doses, but this remains exceptionally rare. And a main take-home point, at least for me, is that there has been no long-term morbidity associated with any of these reactions, and there has been no fatalities associated with any of these reactions. It's also really interesting that the rates of anaphylaxis are dependent on which diagnostic criteria are used. So we talked a little bit earlier about how anaphylaxis is a clinical diagnosis and you look at a constellation of signs and symptoms, but there are multiple different diagnostic criteria that can be used. And for vaccine allergies, we traditionally use the Brighton criteria because it gives levels of diagnostic certainty. But more commonly in the allergy world, for other allergic reactions, we use the World Allergy Organization criteria or the National Institute of Allergy and Infectious Diseases criteria. And there was a very interesting study that was recently done that looked at all the cases of allergic reactions following the COVID-19 vaccines and re-adjudicated them, not based on Brighton, but based on the World Allergy Organization, or the NIAID, and found that up to 70% of those that had been diagnosed as anaphylaxis based on Brighton would not be, based on other allergic criteria. In terms of risk factors, there have been a few that have been potentially identified so far. We are seeing, or there have been more reactions described in females compared to males thus far. There have also been more reactions described among those who have other allergic conditions, but there's a really big asterisk, at least for me, next to that risk factor. The reason being that allergic reactions in the general population, or allergies in the general population, are incredibly common. So allergic conditions are among the most common chronic conditions of childhood and adolescence and adulthood. And in fact, self-reported allergy is even much higher than allergist diagnosed allergy. So many people are walking around with allergic conditions. We don't know the rate of people with allergic conditions who have tolerated the vaccine. And as a result, we really can't quantify risk with respect to previous allergic conditions. Next slide, please. So anaphylaxis rates for COVID-19 vaccines in Canada are similar to those reported around the world. As of October 29th, there have been 539 cases of anaphylaxis following COVID-19 vaccines, and there have been 0 fatalities identified. When you look at the rate per million doses, you see similar rates to the overall trend internationally. For Pfizer, it's about 10 per million, Moderna about 7.8 per million, and AstraZeneca 7.5 per million, with a total rate of 9.3 per million. Next slide, please. So when we look at vaccine reactions historically, so prior to the COVID-19 vaccines, we look at excipients. So excipients are things that are added to vaccines for a specific purpose, whether it's to stabilize the vaccine or to stimulate a stronger immune response or to prevent it against or bacterial contamination. Excipients are added in for a purpose to the vaccine. And historically, that's been what has triggered allergic reactions. So when you look at the components in the COVID-19 vaccines, this is what you see. So the mRNA vaccines contain polyethylene glycol, or PEG. The viral vector vaccines contain polysorbate, and thus far, Moderna contains tromethamine, or tris. But there's something really important to know about these excipients, in particular PEG and polysorbate, and that's that these compounds are ubiquitous. They are everywhere. They're in cosmetics, they're in foods, they are in drinks, they're in toothpastes, they're in multiple other medications. It would be rare to get through your life having not been exposed to PEG and or polysorbate. And in fact, for PEG, which is in the mRNA vaccines, prior to the mRNA vaccines, reports of PEG allergy were limited to case reports. This was considered an exceptionally rare allergy, despite PEG really being everywhere. I'm going to talk about some of the studies that have looked at revaccinating people who have had allergic reactions following the COVID-19 vaccines. But what you'll see is that there is increasing literature to suggest that either these excipients are not triggering the reactions or that the reactions may not be IgE mediated. Next slide, please. So there has now been a lot of studies that have looked at revaccinating people who have had an immediate severe allergic reaction to a previous dose of, it's in particular the mRNA COVID-19 vaccines. That's where the literature is really focused. And I'm only going to go through 4 studies, but these studies illustrate the overall broad trend that we're seeing in the literature, which is that most of these individuals can be safely revaccinated with another mRNA vaccine. So the first study was a study done out of the United States. They looked at 189 people who had had an immediate allergic reaction following an mRNA vaccine. 32 or 17% met criteria for anaphylaxis, and 159 were revaccinated. And this study was retrospective, meaning it looked back instead of looking forward. So they revaccinated all 159 of these people, and all of them tolerated the second dose. And how they defined tolerance was either no reaction or a mild reaction that was either self-limited or resolved with antihistamines. And of those that were revaccinated, 80% had no reaction at all. 20% had these mild symptoms that either were self-limited or resolved with antihistamines. And among those 159 that were revaccinated, 19 or 59% of those who met criteria for anaphylaxis were successfully revaccinated with either no or mild symptoms. The next study is a study of 18 adults in Israel who had an allergic reaction following the Pfizer vaccine. 36.8% met criteria for anaphylaxis. So they did some investigations. They did allergy testing or skin testing to the vaccine in 15 out of the 18. They did testing to polyethylene glycol or PEG in 16 out of the 18. All of the tests were negative. All 18 were revaccinated. 14 out of 18 had no reaction at all. 4 had, once again, these milder reactions. None required epinephrine. None required an emergency department visit. The third study was a study based out of the US and Denmark of 47 healthcare workers who had had an allergic reaction following the Pfizer vaccine. 8 met criteria for anaphylaxis. And this study had a wonderful title. Included in the title was "Don't give up on the second dose," basically, if there's a reaction with the first. They focused this study on the 8 that met criteria for anaphylaxis, and once again focused on the excipient. So they look at PEG, and they ruled out PEG allergy either with testing, which was negative, or a challenge. So half of them, they actually gave a medicine containing PEG in the allergy clinic, no one reacted, or a tolerance history. So in 1 out of the 8, they had actually tolerated a medication that had PEG in it after the reaction. All 8 who met criteria for anaphylaxis were revaccinated. All 8 tolerated the second dose with no or a significantly milder reaction. None required intramuscular epinephrine. Now, the final study is a very small study, only 4 patients, but I picked the study in particular because all these patients had quite significant reactions to the mRNA vaccines, including one that was admitted to the ICU. They did testing to the vaccine in all 4 cases. The tests were uniformly negative. And then 3 out of 4 received a subsequent dose with either no or mild symptoms. Only 1 out of the 3 required any medication at all, and it was acetaminophen or Tylenol, as it's better known, for a headache. So no one needed allergy medication after the vaccine. Next slide, please. So the previous NACI recommendations as of end of September of this year was that if there had been a severe immediate allergic reaction like anaphylaxis after previous administration of a COVID-19 vaccine, an authorized vaccine with the same platform should not be routinely offered. So if you had had an immediate allergic reaction after the mRNA vaccine, a second dose of the mRNA vaccine should not be routinely offered. But if a risk assessment deemed that the benefits outweighed the risks, and if informed consent was provided, you could use a different platform for reimmunization. So if there'd been a reaction after mRNA, you could give viral vector or the reverse. And then finally, an authorized COVID-19 vaccine should not be routinely offered to individuals who are allergic to a component of the vaccine or its container. Next slide, please. However, in October 22nd of this year, NACI revised its recommendations, and we'll go through those on the following slide. If you want to access them, if you go to canada.ca/NACI, you can see all the NACI statements, including the updated recommendations. Next slide, please. So the current NACI recommendations as of October 22nd this year are the following. If you've had a history of a severe immediate allergic reaction after previous administration of an mRNA COVID-19 vaccine, and of course we use the 4 hours because that's the common descriptor for the time interval for a reaction following a vaccine that could be categorized as anaphylaxis, revaccination may be offered with the same vaccine or the same platform if a risk assessment deems the benefits outweigh the individual risks, and if informed consent is provided. If this is done, consultation with an allergist or other appropriate physician should be sought prior to revaccination. Next slide, please. If revaccinated, vaccine administration should be done in a controlled setting with expertise and equipment to manage anaphylaxis. An individual should be observed for at least 30 minutes after revaccination, and it says at least because if they start to have signs or symptoms suggestive of an allergic reaction, you would observe them for a longer period of time. Next slide, please. For viral vector vaccines, if there has been a history of a severe immediate allergic reaction after previous administration of a viral vector COVID-19 vaccine, revaccination may be offered with an mRNA platform if A risk assessment deems the benefits outweigh the risks, and if informed consent is provided. Similarly, if revaccinated, individuals should be observed for at least 30 minutes after revaccination. Next slide, please. So when you're looking at components of the vaccine or its container, in individuals with a confirmed severe immediate allergy to a component of a specific COVID-19 vaccine or its container, so for the mRNA vaccines, you're thinking about PEG, consultation with an allergist is recommended before receiving the specific COVID-19 vaccine. And in most people who have a confirmed allergy, they probably already have allergist involvement. Individuals who are allergic to tromethamine, which is found in Moderna, should be offered Pfizer, which at this time does not contain the excipient. And individuals who are allergic to polysorbates, which are found in the viral vector vaccines, they should be offered an mRNA vaccine. Next slide, please. So other COVID-19 vaccine precautions related to allergies. The biggest take-home point here is actually the bar at the bottom. No precautions are needed for people who have food allergy, for people who have environmental allergies, for people who have stinging insect allergies, for people who have unrelated drug allergies. Anybody that falls into this bucket can be vaccinated with no screening ahead of time, no prolonged observation. People who have had previous mild to moderate allergic reactions, which are limited in scope, can be vaccinated and observed for at least 30 minutes following vaccination. And for this group of people, consultation with a physician or nurse with expertise in immunization may be warranted. People with suspected but unproven allergies to a COVID-19 vaccine ingredient like PEG can just be vaccinated and observed for at least 30 minutes following vaccination because these allergies are thought to be exceptionally rare. And people with severe allergies to injectable therapies, such as other vaccines or medications, don't need any screening ahead of time or consultation ahead of time. They can be vaccinated as per usual, but should be observed for at least 30 minutes following vaccination. Next slide, please. So key takeaways for healthcare professionals. There's emerging evidence that individuals who have had an immediate allergic reaction to the mRNA vaccine can be safely revaccinated with the same vaccine platform. And as a result, NACI has revised their statement on contraindications. If you're going to proceed with revaccinating someone with a previous severe immediate reaction to COVID-19 vaccine, providers should weigh the risks and benefits, provide informed choice, and refer to an allergist or physician with expertise in anaphylaxis. If revaccination occurs, the patient should be in a controlled setting with expertise in both diagnosing and managing anaphylaxis, and they should be observed for at least 30 minutes or more if they demonstrate an allergic reaction. Next slide, please. So here are some resources on revaccination. The Canadian Society of Allergy and Clinical Immunology has a whole section on COVID-19 vaccines and allergies. There's also a COVID-19 vaccine testing and administration guide for allergists and immunologists through the CSACI that is being updated as we speak. And then the Special Immunization Clinic Network, which is a wonderful network of ID docs and allergists that provide standard assessment of patients who have had reactions following vaccination. And if you go on their website, you can actually refer patients directly to them. Next slide, please.
Thank you so much, Alyssa, for that fantastic presentation. So one of the key components of vaccine safety is post-market surveillance. So in order to ensure that we have an accurate understanding of the incidence of adverse events following immunization, we rely on the reporting of those events. Ensure that you're aware of how to report an adverse event following immunization when it does occur. A copy of this presentation with live hyperlinks will be made available after the webinar on the CANVax website, so you can access the AFI reporting links in this slide. Next slide, please. We want to ensure that healthcare providers are aware of a program that compensates individuals in the rare event that they experience a serious and permanent injury following a Health Canada authorized vaccine. More information about the program is available on the website provided on this slide. That concludes the presentation portion of our webinar. A recording of this presentation will be emailed to all of you and posted on the CANVax website. For recording and slides from today's webinar and past webinars, they are also available on the canvax.ca website. Upon exiting, you'll be asked to complete an evaluation survey. We appreciate your feedback and use it to inform future programming. Next slide, please. As we move to the question and answer period, I'd like to remind you that this session will be taking place using the Q&A tab. Please provide questions that are directly related to the topic of anaphylaxis and COVID-19 vaccines. You can like other people's questions to push them up in priority. We will answer as many questions as possible, but we might not get to all of them. So looking at our first question, is revaccination for people with previous anaphylaxis done in a hospital? What is the controlled setting that is recommended for revaccination?
Yeah, so great question. So it would be done in consultation with an allergist or other physician who is comfortable in the diagnosis and management of anaphylaxis. And there may be some variance in where that occurs. In many cases, it may be done through the special immunization clinic. If it's considered at all, it would have to be done in a setting where people are comfortable both diagnosing and managing allergic reactions should they occur.
All right, thank you. Another question we've been getting in various forms is questions about this climate of vaccine mandates and passports, and how having new recommendations around anaphylaxis impacts things like that, when people are seeking exemptions to passports or other mandates.
Yeah, so that's a great question. And NACI doesn't determine specific vaccine exemptions or a specific vaccine mandate. So that's outside of the scope of NACI. But certainly, having this option available to people who have had an allergic reaction following the first dose provides them with the opportunity to have added protection against severe COVID-19 outcomes like hospitalizations and that kind of stuff. So it does open up the possibility of added protection against the virus, done in consultation with an allergist, and of course, examining the individual benefits and risks for any particular patient.
Thanks so much for clarifying. So given that some of the reactions can happen as long as 4 hours after anaphylaxis, or pardon me, after vaccination, how is it determined how long you should wait after or be observed after being vaccinated?
Yeah, so that's a great question. So when we were looking at how long to be observed, we looked at some of the North American data on when reactions were occurring post-COVID-19 vaccination. And then we also looked at the studies that were done on revaccination to look at how long after the first dose it took for the reaction to present itself. And basically the vast majority, almost all, could be diagnosed within 30 minutes after vaccination.
Thank you. And we're getting a lot of questions about, let me see, I'm just scanning through the chat here. So if people have an allergic reaction to one vaccine, they're trying to decide, should they get that same vaccine or another vaccine? And what is the likelihood of having a reaction? For instance, someone mentioned Johnson & Johnson, having a reaction to Johnson & Johnson. How concerned should they be about getting a booster of another vaccine platform?
Okay, so that's a very interesting question. And, the vast majority, really almost all of the literature looking at revaccination in those who have had an allergic reaction has focused on the mRNA-based vaccines. And certainly in Canada, right now, there's a preferential recommendation for the mRNA-based vaccines in general. There isn't a lot of literature looking at, how common is a reaction if you have how common is a repeat reaction if you have a reaction to one vector and you're revaccinated with another. But in some of the studies, there have been a subset that have just been revaccinated with a different platform and they don't report on the outcomes, which I would hypothesize would mean that it's been okay. But that is a bit of a gray area in the literature.
Thank you. I always appreciate it when we can acknowledge where there's a little bit of a lack of information. So we're just doing the best with what we have, right? Another question we got was, what is the recommendation for patients diagnosed with ORS or ocular respiratory syndrome versus anaphylaxis? How is the differentiation made ruling out anaphylaxis for patients who reacted to the first dose and subsequently dose 2?
So that sounds like quite a specific patient question. And I would hesitate to give too much of a broad answer to that. What I would recommend for that specific individual, because that's a less common thing, would be to speak with their individual allergist or healthcare provider about that.
Great, thank you very much. I think that mostly concludes the questions. We've gotten a lot of good variety covered. So we're going to conclude our question and answer period. I'd like to thank Dr. Abrams for her presentation and answering our questions today. And thank you all for joining us. We hope the information provided will help you in your practice. And we'd like to extend a thank you to all healthcare providers and those working in vaccination programs for efforts during the COVID-19 pandemic. The recording and today's slides will be available on the CANVax website. Please fill out the short evaluation when you leave the webinar. These surveys are important to future planning. Thank you.